students, today we will talk about drugs acting on central nervous system, and the main objectives of today's deliberation are introduction about central nervous system, to know about general anesthetics, to get knowledge of sedatives and hypnotics, and to know about anti-epileptic drug, anti-parkinsonism drug, and to study about anti-Alzheimer's drug. So first and foremost, concept of central nervous system. The central nervous system is the part of the nervous system consisting of the brain and the spinal cord. The central nervous system is so named because it integrates information it receives from and coordinates and influences the activity of all parts of the bodies. The central nervous system consists of the two major structures, the brain and the spinal cord. The brain is encased in the skull and protected by the cranium. The spinal cord is continuous with the brain and lies caudally to the brain and is protected by the vertebrae. Now moving to the general anesthetics. General anesthetics are drugs which produce reversible loss of all sensation and consciousness. The cardinal features of general anesthesia are loss of all sensation, especially pain, sleep and amnesia, immobility and muscle relaxation, abolition of somatic and autonomic reflexes. Now the inhalation. Inhalation anesthetics are gases or vapors that diffuse rapidly across pulmonary alveoli and tissue barriers. The depth of anesthesia depends on the potency of the agent and its partial pressure in the brain, while induction and recovery depend on the rate of change of partial pressure in the brain. Now, what are the factors affecting the partial pressure of anesthetic attained in the brain are partial pressure of anesthetic in the inspired gas. This is proportional to its concentration in the inspired gas mixture. Higher the inspired tension, more anesthetic will be transferred to the blood. Second is pulmonary ventilation. It governs delivery of general anesthesia to the alveoli. Hyperventilation will bring in more anesthetic per minute and respiratory depression will have the opposite effect. Influence of minute volume on the rate of induction is greatest in the case of agents which have high blood solubility, because their partial pressure in blood takes a long time to approach the partial pressure in alveoli. Third is alveolar exchange. The GAs diffuse freely across alveoli, but if alveolar ventilation and perfusion are mismatched, as occurs in eczema and other lung disease, the attainment of the equilibrium between alveoli and blood is delayed. Well-perfused alveoli may not be well ventilated. Blood draining these alveoli carries less anesthetic and dilutes the blood coming from ventilated alveoli. Induction and recovery both are slowed. And fourth is solubility of anesthetic in blood. This is the most important property determining induction and recovery. Large amount of an anesthetic that is highly soluble in blood must dissolve before its partial pressure is raised. The rise as well as fall of partial pressure in blood and consequently induction as well as recovery are slow. Drugs with low blood solubility, for example, sevoflurane, desflurane, induce quickly. And fifth is solubility of anesthetic in tissues. Relative solubility of the anesthetic in blood and tissue determines its concentration in that tissue at equilibrium. Most of the general anesthesia are equally soluble in lean tissues as in blood, but more soluble in fatty tissue. Now, the another part, that's intravenous anesthetics, that are fast-acting drugs. These are drugs which on IV injection produce loss of consciousness in 1 arm brain circulation time. They are generally used for induction because of rapidity of onset of action. Anesthesia is then usually maintained by an inhalation agent. They also serve to reduce the amount of maintenance anesthetic. Supplemented with analgesics and muscle relaxants, they can also be used as the sole anesthetic. Now thiopentone sodium. It's an ultra-short acting thiobarbiturate highly soluble in water yielding a very alkaline solution which must be prepared freshly before injection. Extravasation of the solution or inadvertent intra-arterial injection produce intense pain, necrosis and gangrene can occur. Injected IV as a 2.5% solution, it produces unconsciousness in 15 to 20 seconds. Its undissociated form has high lipid solubility, enters brain almost instantaneously. Initial distribution depends on organ blood flow. Brain gets large amounts. However, as other less vascular tissues, for example, muscle, fat, gradually takes up the drug. Blood concentration falls as it back diffuse from the brain. Consciousness is regained in 6 to 10 minutes. Now moving to the halothane. It's a volatile liquid with sweet odor, non-irritant and non-inflammable. Solubility in blood is intermediate. Induction is reasonably quick and pleasant. It's a potent anesthetic. Precise control of administered concentration is essential. For induction 2 to 4% and for maintenance 0.5 to 1% is delivered by the use of a special vaporizer. It's not a good analgesic or muscle relaxant, but it potentiates competitive neuromuscular blockers. Halothane causes direct depression of myocardial contractility by reducing intracellular calcium ions concentration. Halothane causes relatively greater depression of respiration. Breathing is shallow and rapid. Partial pressure of carbon dioxide in blood rises if respiration is not assisted. Cerebral blood flow increases. Ventilatory support with added oxygen is frequently required. It tends to accentuate perfusion ventilation mismatch in the lungs by causing vasodilation in hypoxic alveoli. Pharyngeal and laryngeal reflexes are abolished early and coughing is suppressed while bronchi dilate. Now the propofol. It's an oily liquid employed as 1% emulsion. Unconsciousness after propofol injection occurs in 15 to 45 seconds and lasts 5 to 10 minutes. Propofol distributes rapidly. Elimination time is much shorter than that of thiopentone due to rapid metabolism. Intermittent injection or continuous infusion of propofol is frequently used for total IV anesthesia when supplemented by fentanyl. It lacks airway irritancy and is not likely to induce bronchospasm, preferred in asthmatics. It's particularly suited for outpatient surgery because residual impairment is less marked and shorter lasting. Now moving to the ketamine. This unique anesthetic is pharmacologically related to the hallucinogen phenylcyclidine. It induces a so-called dissociative anesthesia characterized by profound analgesia, immobility, amnesia with light sleep. The patient appears to be conscious, that opens his eyes, makes swallowing movements and his muscles are stiff, but he is unable to process sensory stimuli and does not react to them. Thus, the patient appears to be dissociated from his body and surroundings. The primary site of action is in the cortex and subcortical areas, not in the reticular activating system, which is the site of action of barbiturates. Now moving to the sedative. Sedative is a drug that subdues excitement and calms the subject without inducing sleep, though drowsiness may be produced. Sedation refers to decreased responsiveness to any level of stimulation, is associated with some decrease in motor activity and sedation. Now the hypnotic. It's a drug that induces or maintains sleep, similar to normal arousable sleep. This is not to be confused with hypnosis, meaning a trance-like state in which the subject becomes passive and highly suggestible. The sedatives and hypnotics are more or less global central nervous system depressants with somewhat differing time action and dose action relationships. Those with quicker onset, shorter duration and steeper dose response curves are preferred as hypnotics, while more slowly acting drugs with flatter dose response curves are employed as sedatives. Now the phenytoin. It was actually synthesized in 1908 as a barbiturate analog, but shelved due to poor sedative property. Its anticonvulsant activity was specifically tested in 1938 in the newly developed electroshock seizure model, and since then is a major anti-epileptic drug. Phenytoin is not a CNS depressant. Some sedation occurs at therapeutic doses, but this does not increase further with dose. Rather, toxic doses produce excitement and muscular rigidity. The most outstanding action is abolition of tonic phase of maximal electroshock seizures, with no effect on or prolongation of clonic phase. It limits spread of seizure activity. Tonic-clonic epilepsy is suppressed by paroxysmal focal EEG, that is electroencephalogram discharge, and aura persistis. Now its mechanism of action. Phenytoin has a stabilizing influence on neuronal membrane, prevents repetitive detonation of normal brain cells during depolarization shift that occurs in epileptic patients and consists of a synchronous and unusually large depolarization over which action potentials are superimposed. This is achieved by prolonging the inactivated state of voltage sensitive neuronal sodium channel that governs the refractory period of the neuron. As a result, high frequency discharges are inhibited with little effect on normal low frequency discharges, which allow sodium channels to recover even when their inactivation is prolonged. This effect has been noted at therapeutic concentration of phenytoin, while other effects like reduction in calcium ions influx, inhibition of glutamate and facilitation of GABA responses have been demonstrated at higher or toxic concentrations. Intracellular accumulation of sodium ions that occurs during repetitive firing is prevented. Therapeutic concentrations have no effect on resting membrane potential. Normal synaptic transmission is not impaired. Phenytoin, in contrast to phenobarbital and valproate, does not interfere with kindling. Its ability to selectively inhibit high-frequency firing confers efficacy in trigeminal neuralgia and cardiac arrhythmias as well. Absorption of phenytoin by oral route is slow, mainly because of its poor aqueous solubility. Bioavailability of different market preparations may differ. It's widely distributed in the body and is 80 to 90% bound to plasma proteins. Phenytoin is metabolized in liver by hydroxylation. The kinetics of metabolism is capacity limited, changes from first order to zero order over the therapeutic range. Phenytoin is a first-line anti-epileptic drug, but less commonly used now because side effects are frequent and marginal overdose causes steep rise in plasma concentration, producing neurotoxicity. Indications are generalized tonic-clonic, simple and complex partial seizures. It's ineffective in absent seizures. Second, status epileptics, occasionally used by slow IV injection. Third is trigeminal neuralgia. Second choice drug to carbamazepine. Now moving to another part, that is anti-Parkinsonian drugs. These are drugs that have therapeutic effect in Parkinsonism. The use of pharmacotherapy will depend upon the degree of incapacity of the patient and is generally not justified until symptoms compromise working ability and social relationships. Although levodopa is used in the early stages in some patients. Close supervision is then needed to ensure that treatment regimens are tolerated and then appropriate changes are made to the regimen as the disease progresses. The most effective form of therapy is a combination of levodopa and peripheral dopa decarboxylase inhibitor such as carbidopa. The response to levodopa with carbidopa is a compromise between increased mobility and adverse effects. Dyskinesis may be dose limiting and increasingly frequent with increased duration of treatment. Many factors including tolerance and progression of the disease may result in complications after 2 to 5 years of treatment. End of dose deterioration occurs when there is a reduced duration of benefit from a dose, resulting in disability and dystonesis. The on and off phenomenon is characterized by sudden swings from mobility to episodes of akinesia, tremor and rigidity lasting from a few minutes to several hours. Psychiatric symptoms inducing disruption of sleep, vivid dreams and hallucinations are characteristic adverse effects that may occur at any time, especially in the elderly, and may require dose reduction or withdrawal of levodopa. Treatment for idiopathic parkinsonism is often initiated with a dopamine receptor agonist such as bromocriptine. Now the CNS stimulants, that is central nervous system stimulants. These are actually the drugs whose primary action is to stimulate the CNS globally or to improve specific brain functions. The CNS stimulants mostly produce a generalized action which may at high doses result in convulsions. Now the cocaine. It's a natural alkaloid from leaves of Erythroxylon coca, a South American plant growing on the foothills of the Andes. The natives of Peru and Bolivia habitually chew these leaves. Cocaine is a good surface anesthetic and is rapidly absorbed from buccal mucous membrane. It was first used for ocular anesthesia in 1884. Cocaine should never be injected. It's a protoplasmic poison and cause tissue necrosis. Cocaine produces prominent central nervous system stimulation with marked effect on mood and behavior. It induces a sense of well-being, delays fatigue and increases power of endurance. In susceptible individuals, it produces a state referred to as high, leading to a strong psychological but little physical dependence. Cocaine is unique among drugs of abuse in not producing significant tolerance on repeated use. Sometimes reverse tolerance is seen. Behavioral effects are experienced at lower doses. Cocaine also stimulates vagal center, bradycardia, vasomotor center, resulting in rise in BP, vomiting center causing nausea and vomiting, temperature regulating center causing pyrexia, also due to increased heat production as a result of enhanced muscular activity. In the periphery, it blocks uptake of adrenaline into adrenergic nerve endings, resulting in higher concentration of the transmitter around the receptors. Sympathomimetic effect, potentiation of directly acting sympathomimetics and suppression of indirectly acting sympathomimetics. Local vasoconstriction causes tachycardia, that's rise in BP, and mydriasis are the manifestation of its sympathomimetic action. The only indication for cocaine is in ocular anesthesia. However, it causes constriction of conjunctival vessels, clouding and rarely slowing of cornea, that is due to drying and local tissue toxicity. Its use, therefore, is not warranted. Now moving to another drug, that's donepezil. This cerebroselective produces measurable improvement in several cognitive as well as non-cognitive activities of daily living, scores in Alzheimer's disease, which is maintained at least after 2 years. The benefit is ascribed to elevation of acetylcholine level in the cortex, especially in the surviving neurons that project from basal foremembrane to cerebral cortex and hippocampus. Cholinergic side effects are mild. Because of long time period, donepezil is administered once daily at bedtime, a distinct advantage over rivastigmine and galantamine, which need twice daily dosing. Donepezil is generally well tolerated and is not hepatotoxic. This brings us to the end of the lecture. Hope you have enjoyed and understood. Thank you and goodbye.